for 8 o'clock in the or 7:45 in the morning on holidays. So well done. Give yourselves a pat on the back, round of applause, whatever it is. But it's awesome to see you all here. Good morning to everyone on the live stream as well. We are seeing lots of people of you watching probably from their beds. So feel free to send some photos in. Still the photo competition. We've closed it for today, so we do have some awesome submissions. So we will be running through those photos of the day this morning and giving away some of our t-shirts. Very similar format to yesterday. We've got 3 presentations. We'll do the first one, have a quick little break, and then we'll probably run straight from the second to the third one. We'll play it a bit by ear though, but as always, feel free to jump up, refill your coffees, walk around the back, whatever you guys need to stay comfortable for the couple of hours that you're here with us. If you are struggling to see the screen or anything like that, there are plenty of seats sort of around the front. So also please don't be shy if you feel like you need to sort of get up and move to get a better view. First presentation, I think pretty aptly sort of a topic for Wednesday morning, all about sleep. So let's welcome Erika up on stage to talk about sleep.
Thanks very much, Quentin. Yeah, I'm actually really impressed to see the turnout this morning. I actually thought I might turn up and just have about 5 people here for a presentation on sleep. Who's jet lagged at the moment? Who's feeling a little bit out of sync with time zones? Anyone here? My name's Dr. Erika Hollow and I'm a fellow of the Royal New Zealand College of GPs and also a member of the Australasian Society of Lifestyle Medicine. I also have a background working as a medical registrar and as an emergency MOS for quite a few years, so I have a lot of experience in trying to manage shift work and sleep. Part of my interest as a lifestyle medicine doctor is thinking about the lifestyle factors that help us prevent and reverse chronic diseases, also thinking about increasing our health span and things that we can do to feel better in the day-to-day. I know as healthcare professionals we spend a lot of time also caring for other people, so one of the things I wanted to do in the presentation today is to talk about what we can do for our own health to look after ourselves. This is a little photo of my grandson who was meant to be taking a nap. And I think like all of us from time to time when we're trying to sleep during the day, maybe after a night shift, the temptation is I just can't get to sleep, so climb out of bed and do something else instead. And he was very kindly rearranging the kitchen cupboards. As I was looking through some of the research relating to shift work and health issues, I came out this really surprising statistic which actually shocked me, and that was that people that work night shift have a 25% increased risk of cerebrovascular disease. So that's just to kind of put it in perspective a little bit today about just one of the impacts that working regular night shift can have on our health. And I want to run through a few things today that might help us prevent some of these issues. So what I'm going to quickly cover over is just a really brief skim through at a really basic level, the 2-process model of sleep regulation. So that's a little bit about the biology of sleep. We're then going to run into a little self-assessment, which will just take a couple of minutes to figure out your own chronotype, and then we'll cover why that's important. We'll talk about the diagnosis of shift work sleep disorder, cover a few protection strategies that you guys can think about, how you can integrate that into your daily life to improve your sleep if you're working shift work, and then hopefully you'll be able to pick one of those specific things that you can implement and take home to use. Just out of interest on a quick poll here, how many people actually do shift work in the room? Yeah, so heaps of you. I guess that would be the case. I'm very fortunate now as a rural GP that I do some on-call, but not the 3-shift rotations that I used to do. So yeah, this is really important for all of our health. So I'll jump straight into talking about the 2-process model of sleep, which I'm sure some of you will be familiar with. There's 2 balanced processes that are really important in our sleep regulation. The first one's called process S, and that's our homeostatic sleep pressure. So that's what we feel when we've been awake for some time. You know, if you've done like 24 hours straight, which some of us will have done basically with jet lag or with a really long shift before, and it just becomes almost impossible to stay awake. That's because adenosine, which is a chemical produced in our brain as we are awake and active, is building up in our brain, and then that increases our sleep drive. How many people have had coffee this morning? I can see a few cups around. Yeah. So what coffee does, or caffeine, is that it blocks the adenosine receptors in our brain. So meanwhile, our brain's still working away, and the adenosine's still building up, but we just can't feel the effect of it. And then, you know, as we all know, a few hours later, the caffeine wears off and the adenosine all hits at once, and we feel quite tired. The interesting thing about adenosine is when we drop off to sleep, when we do eventually go to sleep, the adenosine's cleared from our brains really quite rapidly. And I was surprised to learn that after about 4 hours, the adenosine's almost completely cleared again. So we would actually wake up normally after about 4 hours of sleep, unless we had the circadian clock, which is process C, also going on in the background. And that tends to ramp up our alertness during the morning, keep us awake during the day, and then switches off generally for most people, if they're not doing shift work, in the evening. And one of the most significant parts of that circadian clock is melatonin, which I'm sure we've all heard about, which gets released in the brain in the evenings normally when we're in a good routine, and that helps keep us asleep during the second half of the night when that adenosine sleep pressure has dropped. So I've done a lot of talking and a lot of words on the slide, but I thought I'd pop up a little visual of what happens. So you can see process S, which is that sleep pressure that increases as you're awake, and then as you sleep it drops off again. If you stay awake for a prolonged period, you're getting that increased sleep pressure, and then in the background process C, which is the circadian clock, just fluctuating day and night over the whole system. The other thing I wanted to mention is that when you get a disrupted sleep cycle, you can see here we're getting a bit of a phase shift. So that happens in shift workers and also obviously in people who are jet lagged. So you can see that that sleep cycle has been disrupted and pushed forward as people are staying awake later and then trying to sleep with that sleep pressure spike coming up, perhaps later in the day, but the circadian clock is still trundling along below. So you get that conflict and desynchronization between your sleep pressure and your circadian pacemaker, and that's what is one of the main causes of sleep problems in shift workers. So I've talked a little bit about process S and adenosine. Just a quick flick through what's setting our circadian clock. The most important one about that, the most important factor is actually exposure to light and darkness. So that's the thing that sets our underlying circadian rhythm. But some of the others include things like feeding, timing, exercise, and other social cues like shift work, rosters, alarm clocks, times that we spend socially interacting with others. And the important thing, we've talked a little bit about the melatonin being released in the brain. That's our central pacemaker for the circadian rhythm. But the other important thing to mention is we've got actually little circadian clocks in every single cell in our body. So these cells and different organs are switching on and off throughout the day depending on when they're needed, and that the whole system is networked and synchronised. So when we're putting our sleep out of whack with shift work, we're not only affecting the brain in concentration, we're actually affecting the whole system, which is why we then end up with other health issues. So what shift work is doing to our biology is we are expecting ourselves to be wide awake and alert when our body is saying we should be asleep, our core body temperature's dropped and our cognitive performance is less. So we're trying to be awake when our body's telling us to be asleep, and then we're trying to sleep during the day when our body is still, our circadian clock's still telling us to be awake. Moving on now to what happens with health. We've already talked about the 25% increased risk of cerebrovascular disease with people that regularly work shift work. And there are a lot of other health issues that can happen. We know that there's an increased risk of metabolic disease, particularly type 2 diabetes and hypertension. There's increased risks of mental health conditions, depression, anxiety, Interestingly, the International Agency for Research into Cancer in 2019 classified night shift as probably carcinogenic. So the reason they made that statement was because we know there's now increased risk of breast cancer, prostate cancer and immune dysfunction as well. Mentioning again about immune dysfunction, there's a reduced efficacy of vaccinations for people that are working night shift, which is another note that really surprised me, which given that we all work in contact with people with infectious diseases is a bit of a concern. And the thing I'm going to talk about mostly today, which is shift work sleep disorder, because I think that's the thing that we have some control over, is improving our sleep. Enough of me talking. What I'd love to do now is to get you to pop on and scan the QR code, and we're just going to take a quick 2-minute break to work out what your chronotype is. So this is just a reduced morningness, eveningness questionnaire, so it's a 5-question questionnaire that is derived from a longer validated questionnaire. We don't have time to go through the longer one, so we're going to do a quick one this morning. And all the data is just stored on your device. I'm not collecting any of it. So I'll just give a couple of minutes for people to run through that, and then we'll get back into the talk. Going. Most people worked for it. Anyone still going with it? Has everyone got answers? My QR code's working, I hope. Tested it before? Great. Okay. So what does your result mean? A lot of us have heard of morning larks and night owls. But chronotypes are continuum, and like any genetic trait, there's a real variety from one extreme to the other. Just to keep things really simple today, we're going to divide it into 3 groups. The first one is the morning type. Can I have a quick show of hands? Who's come back as a morning type? Okay, that's actually quite a few people in the room. It's not surprising you guys are here this morning. So you've got peak alertness in the morning and tend to feel a little bit more tired in the evenings and struggle a little bit more with those night shifts. And at the other end of the continuum, we've got the evening types. Have we got any evening types here? Okay, yeah, top marks to you guys for turning up as well. So they have a lot later sleep and wake preferences and really struggle often with early mornings. So I'll just turn off my 2-minute alarm. And then there's the bulk, people who are supposed to be in the intermediate range. Who's in the intermediate? I'm actually an intermediate. Yeah. So those are the people that actually have the most flexibility for shift work and seem to cope a little bit better with shift changes across the shift. But yeah, so we're just going to go in. The underlying genetics of chronotype are relating to basically your circadian rhythm, your natural circadian rhythm, and that's an inherited trait. That's not something that you can choose. But we do have some flexibility to adjust a little bit, and that's what we're going to talk about today later in the talk, is how we can actually maybe adjust our circadian clocks slightly. Right. Have a quick, you can either have a think yourself, if we haven't got time to turn to the person next to you, but have a think about, does the current shift pattern that you're working work with or against your natural preference at the moment? So I don't know if you guys want to have a brief chat about that, or if we just have a chat. Remember, who thinks that it's working, their shift roster that they're working at the moment is reasonably compatible with their chronotype? Yes, maybe a third of people across the room. How many people think it's working against the chronotype, that there's some conflict there? Yeah, so slightly less, and everyone else is sort of in the middle. So everyone feels tired after shift work, right? I know I do as well, when you've been up all night or you've been doing a series of shifts one after the other that are rotating. So what is shift work sleep disorder? We all get a bit tired, but this is a little bit more significant. Who wants to hazard a guess at what the prevalence is of shift work sleep disorder in people that are working shift work? Any guesses for a percentage?
80.
Sorry?
80%.
80%? 80%? Yep. Any other guesses? No, we're saying quite high. Okay, well it's actually lower than that. That's the good news. There's a variety of studies and they vary, so there's no 100% agreement, but the range seems to be around the 25 to 26% of people with actual shift work sleep disorder. I'll define that in a minute. So basically it's where you're getting significant desynchronization in your body clock, and that's starting to have other impacts. So you're having problems with insomnia, difficulty sleeping in between shifts. You're getting excessive sleepiness, which might include accidentally falling asleep at work, which is never a good thing. And also it's causing significant functional impairment. So the DSM-5 diagnostic criteria for shift work sleep disorder are that you've got to have a really persistent or recurrent pattern of sleep disruption, that you've got to have the sleep disruption leading to excessive sleepiness, insomnia or both, and it's causing clinically significant distress and impairment in your functioning, so that's in your social or your work life, and it's got to have been present for at least 3 months. So we're not just talking about a transient thing, we're talking about something that's become much more chronic. The other really important thing to consider is that a lot of people who may have shift work sleep disorder can also coexist with other conditions like sleep apnea, mental health issues, sometimes substance use like alcohol and benzo use a little bit more than normal. So that all these other conditions need to be ruled out and carefully sorted before you can come up with a diagnosis of shift work sleep disorder. I've popped up a bunch of places where you can get support. I've covered New Zealand, Australia and the UK. So anyone from anywhere else? Yeah, okay. Basically, there's some resources there. I won't go through them in detail, but if anyone's interested in doing a little bit more reading after the session today about shift work and sleep issues, there are some great resources there. I just want to give a wee shout out to the Black Dog Institute in Australia, which has a really good e-learning resource about sleep and shift work and how you can help your sleep patterns as well. I would recommend anywhere, if you think that you might be having some problems with shift work sleep disorder in particular, that you go and catch up with your GP and maybe get a referral to a sleep physician, because it is treatable, or have a chat to your occupational health service. Right, we've talked about all the problems. Now, as per lifestyle medicine, I'd love to talk about what we can do to help our own health. So what does the evidence say that we can do? I'm just going to talk about 3 main strategies today, and I picked these out of the American Academy of Sleep Medicine guidelines, which have just been released this year, the updated ones. And I picked them because they're things that we can do ourselves without needing a prescription and without needing to go back and completely overhaul the organisation and the shift roster. The first strategy I want to talk about is light exposure. And the evidence is that if you can, during your shifts, get really bright light exposure, which will probably work quite well if you work in an ED, not necessarily so well if you work on the wards, but making sure that you get really bright light exposure during your shift. So that's going to help you stay awake and also going to help recalibrate your circadian clock. And that's recommended by the American Academy of Sleep Medicine, both to help you sleep and to help you kind of realign. And then after the shift, it's really important that we think about blocking our eye exposure to light on the way home. So that's that blue-green wavelengths of light, which are most prevalent in the morning. That if you're exposed to that, it's going to switch off your melatonin production. You're going to find it quite hard to get to sleep during the day shift, the daytime. So it's you can use some blue light blocking glasses on your commute home. I checked online and they range between about 33 and 140 New Zealand dollars, so they're not a super expensive thing to buy. The only caution I would say is if you are driving home in dim light, please do not wear blocking glasses. You might want to save them till you get home just for a safety issue. And it was a really interesting randomised controlled trial in 2023 which showed that it looked at a group of night shift nurses, and they showed that if you have that nighttime evening light exposure and then avoid that morning light, blue light exposure, they found a 67% reduction in work-related errors, which I thought was quite a lot actually. Second strategy I want to talk about is strategic napping. Like with anything, the dose and the timing is really important. So you have a couple of options. The first one is to take a prophylactic nap about, a couple of hours before your shift if you can, and about 90 minutes. And again, they showed that if you did that, then you're reducing the sleep pressure going in. So this strategy is the first one was looking at your circadian clock. This strategy is looking at process S, so how you can drop that sleep pressure before you're going into a night shift. And you can combine that with caffeine, which we all love for the strongest effect, but you want to be taking that caffeine in the first 4 hours of the shift, not the last 4 hours. And some lucky people might be allowed to actually have a nap during their shift. I don't know if that's possible for anyone here. I don't think it was for me when I was working night shift, but if you have the opportunity to and you're allowed with your organisation, taking a 20 to 30 minute nap in the middle of your shift or during your shift, again, they showed that that has improved your response speed and your alertness over the shift, and that persists all the way through to the end of the shift. The caution though is not to have naps more than 30 minutes, because then your brain gets groggy, you've got sleep inertia, it takes about an hour to wake up again. So if you're having that nap in the middle of the shift, you really want to make sure it's no more than 20 to 30 minutes. The final strategy today is melatonin timing. And I think in New Zealand and Australia now you can buy it over the counter, so you don't necessarily need a prescription for melatonin now. And we're not using it in this situation as a sleeping tablet, we're actually using it to reset circadian clock. And you don't need large doses for that, you only need 0.5 to 3 milligrams. Higher doses just give you more side effects, and they're not shown to be more beneficial in resetting your circadian clock. So there are a couple of times when it's really useful, either after a night shift when you're trying to get to sleep during the day, and it's shown to help shift your circadian window towards being able to sleep more in the daytime. And then the other option is when you're transitioning schedules. So again, obviously when you're going from having worked some night shifts, wanting to go back into your day shift roster, taking that at 1 to 2 hours before bedtime in the evening will just help you reset that circadian clock and get back into a much better sleep pattern and with improved quality of sleep. Again, like with the light blocking glasses, you want to be careful about not taking it before a drive home because it can slightly increase grogginess. You want to make sure that you're taking it when you get home. Right. I thought I'd just pop up 3 examples here for people to have a wee think about, thinking towards the strategy that you think might work best for your roster and your lifestyle. Have a wee think about what strategies that might work for you, and just maybe pick one. It doesn't have to be one of these, but have a wee think about what you can do. And if you'd like to, just set a little reminder on your phone to give you a prompt before you go into your next shift. So just a summary up there, we've covered the really, really basic. It's obviously a lot more complex, but in half an hour, that's all the time I have to go through the 2-process model of sleep. Figured out your chronotype, talked a little bit about shift work sleep disorder and where to go and get some help if you need to. For that, it is treatable, so I don't want anyone going away from here thinking that's just something they have to live with. I've just run through 3 evidence-based strategies, the light management and the melatonin timing, which are working on your circadian clock, and strategic napping, which is working on process S. And then thinking about if you'd like to make a little commitment to try and improve your sleep before your next shift. Right, I'm happy to cover any questions that anyone might have, and I've just got a list of references and contact details there if anyone wants to do any more reading. Thank you.
Any questions for Erika?
Another question?
Oh, I saw a water bottle go up, but not a question.
Yep. Do
Oh.
you want me to have the remote? The microphone? Whatever it's called.
Yes.
You can shout at me.
I can shout.
Thank you, great talk. Very informative, if not a little alarming. I was just wondering, with all these studies about night shifts, what is the definition of a night shift? Because I know a lot of us no longer do night shifts per se, but we still work well into the evening, if not the early hours of the morning. And is that better, / just as bad?
Yeah, I think the traditional shift roster is sort of a night shift between 10 p.m. and 6 a.m. generally, but I know there's a lot more flexibility now. And not everyone works a 3-shift roster. Some people do, 12 hours. I know a lot of ambulance staff do a 12-hour shift where you go on to a series of 2 days, 2 nights, and then 4 off. I don't know if anyone's doing that kind of a roster. Yeah. So that's actually, the research has shown that the 2-shift roster is actually less disruptive on sleep than the 3-shift roster. And also the forward rotation is better than the reverse. So in other words, if you're working to a morning shift followed by an afternoon shift, followed by an evening shift and then some time off, that's actually better than people who are jumping between, say, a night shift and then an afternoon shift. So going backwards is worse, basically, for your body clock. But yeah, I think the studies are really varied and the information is still coming out. There's, obviously a huge variety. So some of these studies were looking at like 30,000 healthcare staff, and across those they would have potentially been looking at all slightly different shift rosters. So I'm not sure there's a definite definition.
Hopefully that gives you guys a taste of what we're after. Don't worry, if you're not hitting up the snow, there's plenty of other photos that we like to see. So all the scenic places around here, there's jet boats, bungee, canyon sweeps, all those sorts of ones. Love to see them, so please keep sending them through. We're now going to move on to our little presentation of the morning. And I think our next person deserves an extra big round of applause because she's here with a very maybe a still slip disc, I'm not quite sure, but a very sore back. She's gotten out of bed, she's moving. So please make Danielle feel nice and welcome to come off the stage.
Thanks, Quentin. I'm also a little bit high on the codeine and the amitriptyline from last night. So thank you for having me, and to the local GP here in Queenstown who prescribed for me all those strep-related drugs too. So today I'm talking about law, risk and decision making in the emergency setting, and we have just over half an hour, which is not a lot of time. Any one of the slides I would usually speak to on for about an hour, so we will speed through these topics. A little bit about me. I am the General Counsel at the Royal Women's Hospital in Victoria, which means I'm a lawyer. I have practiced exclusively in health and medical law for over 15 years. And for my dues, I am married to a paediatric emergency medicine physician as well. So I get it, and I think that helps. I understand what it's like working in an emergency department, not personally, but I certainly have heard many stories over the years. And we've had lots of discussions and debates about what can and can't happen and what the law does or doesn't allow. And certainly one of my master's papers I wrote with the inspiration of my husband and the work that he was doing at the time, and the title of that paper was Is Consent a Luxury in an Emergency Department? And we will talk a little bit about consent too. So let's quickly make sure we're all on the same page about a few topics. Medical negligence. This is usually when somebody sues a hospital in Australia. We have a fault system, different to New Zealand, which has a no-fault system. And there are 4 main areas to prove for medical negligence. Does anyone want to have a guess what they are? Duty of care, yeah, number 1. Once you've established that, what comes next? Breach, yes, breach of duty. Number 3, causation. And number 4, so reasonableness comes in under breach of duty. Damages, yes. All right, let's talk about them then. So very quickly. So duty of care, I hear this not infrequently. People will say, I did this, and I say, oh, why did you do that? I'll say, I had a duty of care. I say, okay, that's not really what that means. So a duty of care is just a legal concept. Lots of people have a duty of care. Employers have a duty of care to their employees to provide a safe system of work. Manufacturers have a duty of care to consumers who purchase their goods. Occupiers, this hotel has a duty of care to all of us who are visiting to make sure it's safe for us to be here. But a doctor's duty of care, or a nurse's duty of care, or a paramedic's duty of care is to exercise reasonable care and skill. That is what your duty of care is. That doesn't mean you can just use that term willy-nilly and say, and this is what I've heard, we restrained this patient because we had a duty of care. That's not quite enough. There's got to be something more to it. The breach, that means that the standard of care fell below that of a reasonable practitioner. So when I'm defending, which is the side of the law that I've only ever practiced on, I'm defending hospitals or doctors or nurses and midwives, and ambulance paramedics as well. What we try and prove here is that what they did do was widely considered as competent professional practice by their peers. And we obtain expert evidence on that. Causation is that the breach caused or materially contributed to the patient's injury or death. But in your setting, in emergency, it is actually rarely that. That test there for causation, the breach causing something, that's usually a direct act or omission. So for example, that could be a surgeon who nicks the bladder in some laparoscopic procedure. The surgeon actually does that. Putting aside whether that's a known risk of the procedure, which they'll always say it is, but putting aside that, in your case, what is most likely to be the situation is a delay in treatment or a delay in diagnosis. So you didn't necessarily cause the initial injury, but the delay is what you're being sued for, or your hospital is being sued for. And the test for that is slightly different. The test for a delay is that the patient has lost the opportunity for a better clinical outcome. And so in the emergency setting, cases I have seen, and I can tell you, I have told the doctors many times with this slip disc, I do not have any cauda equina symptoms. And that is because I have worked on lots of cases for delayed diagnosis of cauda equina. So I know those red flags, and I keep telling them, do not have any of those. But other cases in emergency, and now I'm working at the Women's Hospital, I see a lot of delayed diagnosis for ectopic pregnancies, delayed diagnosis for ovarian torsion, but it's an operation on her blind eye, and there was a risk that the good eye would go bad. And they didn't tell her, and the good eye went bad. She was blind in both eyes. And that was considered, even though it was extraordinarily rare, it was not common, it was definitely serious, but it was not common risk at all, it's very rare. And the court said, well, even though it was so rare, that was really material to that patient. Because she went blind in the other eye, which is what eventuated. Now she can't see at all. And she might not have consented, which is what she says. And there are lots of cases which talk about hindsight bias. Lots of patients, even in my hospital now, still say, well, if you told me about that incredibly rare risk, I wouldn't have consented. And there was one case, a patient had a stroke, she had a PE and had a stroke. And she wasn't warned of the risk of the PE. I can't remember exactly what the surgery was, but it's not really relevant. What was relevant was that she had consented to the risk of death. And in her mind, that was totally fine. But she said, but if I was warned about the PE and the risk of stroke, I would not have consented. And the court said, sorry, we can't accept this evidence. So the hindsight bias that an individual has when they have then lived through what eventuated. We can't place any weight on that. So I use that case a lot to say that the patient, of course the patient says they wouldn't have consented because they've now lived through the 4th degree tear, for example. So informed consent, we've pretty much covered it. There's one thing I wanted to quickly tell you about it being voluntary, free from coercion or undue influence. The reason I want to tell you about this is there's been a recent Supreme Court case in Victoria, Gawthorpe and Bendigo Health. I do know the case very well, but I asked ChatGPT to do 10-point bullet points about this case so that I wouldn't waste time. So, the plaintiff, who's the patient, she was enrolled in Bendigo Health's what's called MUMTA Continuity of Care Midwifery Program, so a group midwife program. And she prepared a detailed birth plan declining vaginal examinations unless there was an urgent medical reason, and that she gave informed consent. Throughout her pregnancy, the hospital staff reassured her that her birth plan and preferences would be respected, creating a reasonable expectation that unnecessary VEs would not occur. When she presented in labour, her caseload midwife was at home, and the hospital midwife informed her that she needed a VE before she would be admitted, before they would administer pain relief, and before contacting the caseload midwife. That was the hospital policy. The patient repeatedly refused the VE, but after being told she would otherwise be denied admission, analgesia, and continuity of care, she eventually submitted while visibly distressed. And the court case says, on the patient's account, she was asked 8 times in a 2-hour period, "Are you ready for the VE yet?" So every 15 minutes. The midwife denied that it was that frequent, but the court ultimately accepted the patient and her husband's account. And so, unsurprising, the Supreme Court held that her apparent agreement was not free and voluntarily provided, but it was a mere submission to overwhelming pressure and coercion. The court found that there was no urgent medical justification for requiring the VE, and her clearly expressed wishes in her birth plan were disregarded. So Bendigo Health was liable for both battery, which is trespass to person, and negligence, because valid consent had not been obtained before the examination. She actually did consent, I think, to 4 or 3 after that, which she said she had no problems with. It was just the first one. She says it was not a medical indication, and it was purely a policy. So my hospital went through our policies and guidelines to make sure that we didn't require a VE prior to admission, which we didn't. It's listed as the things that you might consider, but if a patient does not consent to it, I mean, what was the alternative here? She was just going to sit in the emergency department until she birthed a baby. So that it wasn't really a good policy. So the patient, you might be wondering, what is the damages? For the negligence part, the trespass is obviously established. She suffered psychological injury, including anxiety, flashbacks, panic symptoms, and ongoing trauma resulting from the coerced examination. And it's obviously a landmark Victorian authority, confirming that patient autonomy must be respected. Consent obtained through coercion is invalid, and hospitals must honour informed refusals unless a genuine clinical emergency justifies otherwise. And certainly the fallout from this, my hospital, the clinicians ask me, at what point are we coercing patients to consent to something? We often will say, there is a risk of injury to the baby if we don't go, and we might say that multiple times. Are we coercing them to consent to the cesarean, for example, or an instrumental delivery? That will have to be another case. Okay, let's quickly talk about capacity. So, you will have seen in the last slide, the last part for informed consent, this patient needs to have capacity. And you've already started mentioning some of these things. They need to be able to understand, so the ability to understand information relevant to the decision. They need to be able to retain the information. They need to be able to weigh it up. Somebody said that one as an example. And they need to be able to communicate the decision. And there's lots of cases about capacity that we could talk about. But I thought I would tell you what happened yesterday at my hospital. a patient came in for a elective caesarean section, which she had previously agreed to. And she came in and she was substance affected, had been using substances, and she was dropping in and out of sleep. And the obstetrician said, I can't get consent again because she's not talking. I was like, why isn't she talking? She said, because every time I ask her, she falls back to sleep. I was like, okay, so how are you going to satisfy the last one? That she can communicate. You don't have to communicate verbally, you might know that. It can be lots of ways, you can nod, or there's lots of different mechanisms people can communicate. But in this case, there was no communication. You just kept dozing back off. And so I had to kind of consider, well, had she already previously provided consent? Is there a risk that she might have withdrawn that consent? And then you're going to perform the caesarean section without consent. Anyway, what ended up happening is the patient's been admitted for query tuberculosis. So she's not having didn't have the caesarean yesterday. We'll see what happens today. But that's the type of issue. Also, I was speaking with some lovely local paramedics here in New Zealand on the canapes night, and they talked to me about the difficulty they have with mental health patients. And they might have a patient that they call to go see who has attempted suicide or self-harm, and the patient says, don't take me, I don't want to go to the hospital. And then they're trying to work out whether the patient has capacity to make a decision about declining care. We don't use the word refusing care at my hospital anymore. I've got to move out of that legal jargon. We say declining care. And an adult who has capacity can make an irrational decision. They can make a decision that will cause them more harm, and that is legally okay. As much as I know, it will feel morally distressing, but legally they can decline care that will cause them more harm. Anyway, for the paramedics, I said, I'll just take them to the ED, let it be their problem of whether they treat them or not. That's what I told them. Okay, we don't have a lot more time. We've got about 10 minutes, and I have 4 cases. So now we're kind of on the same playing field about what we're talking about. The medical negligence cases, talking about informed consent, talk about capacity. I'm not going to talk about disciplinary matters, which is where the medical board or nursing and midwifery board would investigate. And we're going to not really talk about mental health patients either. It's a whole other area of law. But let's talk about some of these coronial findings, because clinicians find these really interesting. I don't know what that says about your personalities, but the jurisdiction for coronial investigations and inquests is different to the civil claims. We are not looking to say who's going to compensate someone. There's no money that's awarded in a coronial case. What they do is they investigate reportable deaths, and they look at systemic issues. And that's why I find it's really relevant for ED, because there's often quite a lot of systemic issues in EDs. And they often make some recommendations as well, which I think can be helpful. So let's talk about this first case. And obviously, trigger warning, these are all deaths, given the jurisdiction we're talking about. The first one is about a child. So it was a 6-year-old, had been home from school with a mild flu for several days. His parents were both registered nurses. Over the course of several days, the condition progressively worsened. His parents took him 3 times to a regional hospital where they both worked. He was sent home from the hospital on 2 occasions. On the first occasion, he was informally seen by Dr. C, not my husband, in the emergency department, and provisionally diagnosed with a viral infection. On the second occasion, he was initially seen and assessed by Dr. R, who ordered a chest x-ray. The patient was then sent home the same day by Dr. C, following handover of shift and after reviewing the x-ray. His mother then took him to the medical centre where the GP suspected scarlet fever and insisted he must be admitted to hospital. The consultant paediatrician, Dr. I, admitted the patient to the high dependency unit with a provisional diagnosis of scarlet fever and possible chest infection. He did not recognise that the patient was already showing signs of septic shock. That night, the patient became progressively more unwell and feverish. Eventually, he stopped breathing and couldn't be resuscitated. Pathology reports concluded the cause of the death was bacterial sepsis arising from bacterial pneumonia secondary to influenza. And the coroner found the ultimate cause of death was complications from a natural illness, but it identified several issues and missed opportunities in the patient's treatment. So the first examination was an informal corridor consultation. The patient's father worked in the emergency department and took the patient with him on a social visit. Another staff noticed a rash on the patient's body and insisted a doctor should look at him. Dr. C, the experienced locum on duty, took a history from the father and performed a thorough examination. At that stage, the patient had no temperature or signs of infection and appeared alert and happy. Dr. C considered the patient's symptoms presented like scarlet fever, but in the absence of other clear signs, she diagnosed a viral illness with a differential diagnosis of scarlet fever or tonsillitis, and she provided a PRN prescription for penicillin. The patient went home with his father. The patient had not been formally triaged, so no clinical record was created, and Dr. C did not make notes of the consultation. And at the inquest, it was recognised that Dr. C had been placed in a difficult position. She only recently started working in the department and had felt pressure to see the patient. At the time, informal consultations were not uncommon in this rural regional hospital, and the coroner accepted that the doctor had conducted a thorough examination and formed an appropriate diagnosis. The experts were critical of the poor note-taking throughout the treatment. They were also critical of failures to read other clinicians' notes. This meant that doctors assuming care were unable to benefit from other colleagues' examinations or understand their care or treatment plans. So the coroner was critical of Dr. C's lack of documentation during the patient's initial assessment. It meant that there was no information about assessment when the mother brought the patient back the second time. And the doctor criticised the lack of documentation of any handover discussion between Dr. R and Dr. C. When Dr. R was leaving the hospital, this is at that second presentation, neither doctor had documented any discussion, nor did they document examination. This is her examination of the x-rays, the interpretation of the x-ray. That documentation about handover is really important, particularly in medical negligence cases. We go back and look at that, and someone will say, oh, the plan was blah, blah, blah. And I'll say, oh, okay, where does it say that? I say, oh, that verbally I spoke with the consultant and they told me that. I'm like, oh, okay, where does it say that? Oh, it doesn't say that. I'm like, okay, I'll go ask the consultant. Just confirm, what was the plan? No, that wasn't the plan. Okay, where have you written down what you said the plan was? No, I don't have it either. Okay, great. Now we've got a factual dispute on our team about what happened. Makes it very difficult to defend. When I first started practicing, I remember the partner of the team I worked for said, good notes, good defence. Bad notes, bad defence. No notes, no defence. And I maintain that's probably still true now. So the electronic medical records, for those of us who are privileged to have them, I know not all regional rural hospitals or hospitals have them, but they certainly help. So that case really reflected on the documentation and communication, including the handover communications. Guidelines, guidelines. You hear about this all the time. Especially nurses love guidelines. They always say to me, why did you do that? I said, it's in the guideline. Okay. Why didn't you do what the doctor said? Oh, because that's not in the guideline. In this case, and I'm not critical of the nurses in the room either, because you'll see in this case, they should have followed the guideline. This was a 21-year-old female who presented to a district hospital with a fractured and grazed left ankle after dancing in high heels. The patient was a non-smoker and she was overweight. She was also taking oral contraceptive pill. She was given a tetanus booster and analgesics and started on intravenous antibiotics before being transferred to a tertiary hospital. Her leg was considered too swollen for surgery, so a below-the-knee cast, analgesia and elevation were provided, antibiotics were continued, and the anticoagulant enoxaparin, thanks guys, was administered for 3 days for DVT prophylaxis. She was transferred to another hospital for the swelling to reduce, and that medication and her contraceptive pill were continued. At the time, the patient's father told a staff member about his history of blood clots in the lungs and that he had been prescribed ongoing warfarin. He asked if his daughter would be given blood thinners and was told she was receiving them each night. About 2 weeks later, she was transferred back to the tertiary hospital for surgery. And her surgery was allocated to an orthopaedic registrar to perform an open reduction and internal fixation of the fracture. She was not given enoxaparin before surgery, and her chart shows she received it in the evening following her surgery. The inquest heard that the usual practice at the hospital is that the orthopaedic surgeon who performs the surgery provides the post-operative instructions. And as the usual practice was to consider a patient's need for ongoing thromboprophylaxis at discharge, it was not surprising that the post-operative orders didn't mention it. A day after surgery, an on-call registrar reviewed the patient, discharged her after checking the post-operative instructions, which did not mention enoxaparin or aspirin. The patient was not asked about her family history of VTE or prescribed an anticoagulant. Her father asked a doctor, who introduced himself as one of his daughter's surgeons, whether she would be sent home with blood thinners. He was reportedly told, no, her heart is good, she is young and strong like an ox. And you just know that this sentence is now stuck in this father's memory forever because his daughter is no longer alive. So a month later, the patient saw her GP with shortness of breath, pleuritic, chest pain and vomiting. She was sent to the emergency department of a general hospital where she collapsed and suffered a cardiac arrest in the waiting room. She couldn't be resuscitated. And the coroner attributed her death to pulmonary embolism associated with DVT in her injured leg. So at the time, the hospital had 2 guidelines for thromboprophylaxis for lower limb trauma. The hospital's guideline for fracture with immobilisation recommended enoxaparin starting 6 hours after surgery for the entire period of immobilisation. The orthopaedic department had its own guideline, and it recommended the use of enoxaparin the morning after surgery, followed by 150 milligrams of aspirin on discharge for patients with restricted weight bearing. For high-risk patients, enoxaparin was recommended 6 hours after surgery and warfarin for 6 weeks from the day of surgery. And the events involving this patient highlighted the discrepancy between the 2 sets of guidelines. At the time of the inquest, the hospital was taking steps to align the guidelines. They did not have a good layout. I would have made sure at the time of the inquest the guidelines were aligned. You don't wait until the findings of an inquest. Make sure that your affairs are in order before you get to the inquest, and you often have plenty of time. So there was obviously these differing views on DVT risk. I won't bore you with them. And then the coroner made a number of recommendations, and they talked about clinical guidelines and decision making, and when you depart from guidelines. So there may be good reasons for considered and rational departure from guidelines. They are not the law. But what you do need to make sure you do is document when you choose to go outside of the guideline. It has to be a pretty good reason. So consider whether your peers would agree that departing from the guidelines is appropriate in that patient's circumstances, and document your clinical reasoning for not following the guidelines in that particular case. I've got a case at the moment at my hospital where we followed our guideline, and the experts have all looked at it and said, well, the guideline was wrong. So that was still likely to be found to be medical negligence. There's a case about administering gentamicin to a newborn, and when you do the trough levels, and our existing guideline, which has now been changed, but the guideline at the time was for the 3rd dose, you take the blood, you give the 3rd dose, and then the trough levels come back. And in this case, the trough levels were high. The 3rd dose should never have been administered. And the baby now has bilateral hearing loss. So sometimes the guidelines are not going to be your get out of jail free card. You can't say, oh, we followed the guidelines if they are not right. I might skip this one just in the interest of time. This was cognitive bias leading to a misdiagnosis. This wasn't an ED, and it was a patient who they diagnosed with cannabinoid hyperemesis syndrome. But actually, turns out he had perforated duodenal ulcers. Do you want to hear about it? I feel like the next piece is better, and we don't have a lot of time, particularly if you've got any questions. All right, let's quickly do this one. I feel like this is more your bread and butter. Ms. Q was 68. Just remember the gender issues with diagnosing myocardial infarction. She had a medical history that included osteopenia and an adverse reaction to morphine. She attended a hospital ED after an accident while exercising on a stationary cycle. She explained that she had slipped and struck her ribcage on the handlebars, and she described the event as mechanical rather than in terms suggesting a medical episode. At the time of the event, she experienced a sharp pain, and this was not debilitating but persisted, and the next day caused her to take paracetamol, ibuprofen, and codeine. She began to experience nausea and pain in her upper abdomen and left lower ribs, which continued to intensify. When she arrived at the ED that evening, her vital signs were stable, and she rated the pain at 5 out of 10. A clinician from the rapid assessment team examined her 2 hours after her arrival. They noted Miss Q was dry retching, pale, and appeared uncomfortable, but had normal vital signs, a clear chest, and no difficulty breathing. She had no abdominal tenderness, and the results of an abdominal ultrasound were normal. They formed a preliminary diagnosis of adverse reaction to the codeine rather than a delayed presentation of trauma. 2 hours later, a second clinician examined Miss Q and came to the same diagnosis. She was admitted to the short stay unit for a chest x-ray, blood tests, and medication for the pain and nausea. However, while the treatment plan was being implemented, she experienced cardiac arrest and could not be resuscitated. Sorry, the coding's giving me a dry mouth. An autopsy concluded the cause of the death was acute myocardial infarction caused by coronary artery atherosclerosis. Is that right? Thanks, guys. The pathologist considered the nausea and vomiting that she experienced were symptoms of the evolving MI. The hospital acknowledged that MI had not been considered, tested for, or identified. However, it noted the huge challenge in emergency medicine of diagnosing an atypical presentation. This was compounded where there were other explanations for a patient's symptoms. In this case, her history of recent trauma, adverse reaction to opioids, and her explanation that appeared to rule out a medical episode as the cause of the fall were complicating factors. The coroner accepted the clinician's diagnosis had been reasonable and their care appropriate. They noted the coroner noted the risk that results of an initial rapid assessment may potentially bias a later, more comprehensive assessment. But there was no indication of bias in this case. The coroner recommended that this case be used as a case study to highlight the need to consider acute coronary syndrome as a possible diagnosis in females who may present atypically, that is, not the same as a male. The importance of comprehensive primary and secondary assessments. My hospital's doing like a sex and gender studies right now with the Royal Melbourne next door. One of the things is the delay in women getting ECGs. Again, atypical presentations, those that are of a male, will inevitably be challenging to diagnose. So signs and symptoms don't always follow textbooks written about males. Patterns and factors such as age, gender, or ethnicity, and they can influence how patients present. So it's important to be aware of these variations. Differential diagnosis is an important part of clinical decision making, even when symptoms may have a ready explanation. So taking a moment to consider alternative explanations by asking, what else could explain these symptoms? What happens if I'm wrong? Would my treatment or management change with a different diagnosis? Are there further tests that could confirm or rule out my diagnosis? And when you are asked to provide a second opinion, be mindful of confirmation bias. It's easy to be influenced by an existing diagnosis, particularly if a colleague has already assessed the patient. Even if a second opinion aligns with the initial diagnosis, it's essential to ensure that the conclusion was reached through independent, critical evaluation rather than passive acceptance. We are 1 minute over time. Here are some risk reductions and practical steps you can take a photo of and we can chat about in the break or at the end. Thanks, Quentin. Sorry for going.
No, not at all. That's Erika. Does anyone have a question for Danielle? Yes, excellent. Let me get the mic over.
Thank you, it's very impressive. One of my job is we get about 3 legal claims a week at the district where I work, which is increased over the last few years, which is quite extraordinary. Nearly all of them of psychological harm. Only last week was the first one I've actually seen for a long time that was actually claimed negligence. However, what annoys me, apart from is part of my job is I have to say, is this medically defendable without getting the expert opinions? Statement of claim always comes with the plaintiff's expert opinion, and it's depressing because it's usually from the same 4 people, which their guns are higher, and anyway. So I say, it's medically defendable, or it's not. What annoys me is then I hand it over to the legal people, and they come back and say, it's not legally defensible, it's not worth the cost. Which is really annoying. And one that sticks in my mind was, there was a particular case, bad outcome. I thought it was entirely defendable. I thought, fantastic. And the lawyer's defence, so this is the government solicitor's office, current solicitor, saying, well, we've got our experts, they've got their experts, but they've got a woman in the witness box who's sitting there crying. Unless the jury will always go for the woman, no matter how bad the plaintiff's expert's opinion. So that's the most frustrating part for me.
Yeah, and I do hear that not infrequently. All of those points are valid. Ultimately, if you're deciding whether to go to trial or not, you're trying to weigh up whose evidence will be accepted. And the advice I always say, even if we think we have the strongest evidence, we don't know whose will be accepted on the day, which expert will be believed. And the issue of the patient in the witness box is a real risk. And we know that because there have been cases that have gone before juries and the jury has found in favour of a patient where they have this empathetic response to what has occurred. So that is a risk that we consider when we're determining whether to run a case to trial. And we think of other things too, like, well, what are the consequences if we lose in terms of the precedent it will set for other cases? And can we resolve cases now without that case having a finding? But it is certainly tricky, and I share your disdain with the experts, the hired gun experts.
Any other questions? Time for one more we can take? Yep, how's your voice at the back?
We get a lot of patients who say, I'll just do whatever you tell me, doctor. How do you inform patients who aren't willing to engage in those conversations?
Yes, very tricky, although not the trickiest scenario, I'll tell you some others, but in that case where they say, whatever you think, doctor, what I recommend you say is, I've got a duty of care. I need to make sure that I have told you all the risks involved. So I need to tell you them. I've got an obligation to tell you them. And my recommendation still is that we proceed with the procedure or the treatment, or we don't. But you'll still need to say them. You'll need to demonstrate, otherwise you don't have informed consent. And just remember, an interpreter, sometimes the patient will say, I don't want an interpreter, my family will interpret for me, or no, I don't want an interpreter because I'm in a very small community and the interpreter will know me. Just remember, the interpreter is not just for the patient, it is for you too. And so I always say, make sure if you feel you need the interpreter, you're not seeking the patient's consent to get it, you get it for you. And the other hard one is in obstetrics at the moment, we have patients who put headphones on when the doctors come in and say, I don't want to hear about all the risks, you're ruining my birth experience, and they'll put headphones on so they don't You can say what you want, but they're not listening anyway. I think if anyone wants to have a chat, we can chat in the break right at the end.
All right, let's hear it one more time for Danielle. All right, we have got a bit of a crew to come up on stage, so I reckon give yourself a minute, stretch the legs, do some of your box breathing, whatever it is that you need to do to get engaged, because we're going to start our Q&A very shortly. We just need a bit of a reach up on the stage, yeah.
I didn't leave until 20 past 9. Yeah, it's only 5 minutes. Very good. I was going to show you when the my room back. So we were here.
Okay, everyone, thank you very much for your patience as we did a quick reshuffle with a very professional lying down of the lectern. I always looks like we created a bit of a barrier here, I reckon. We have plenty of seats around the front here, so if anyone wants to get up nice and close, please feel free to. Also, if you do wish to add any comments, make questions or anything like that, we don't have a mic, please do hope to speak in as loud as voice possible, because it might be a little bit hard to run across the room. Now really exciting, I get to introduce you all to one of the other members of the EMS team. For those that were in Queenstown last year, you may have got to wear Oliver's sunglasses at the closing party. They were doing the rounds, so hopefully you have them, please feel like that. But yeah, Oliver's been a great addition to the team. He was in Queenstown last year, Rizutsu this year. He's going to be presenting tomorrow for Victoria, so really excited to have him involved. So I'm going to hand it over to Oliver, who's going to take away for the panel.
Thank you, Christian. Yeah, welcome everyone. Super excited to be here, super excited to be hosting a panel. This is our first ever EMS Unfiltered panel, so we're breaking ground in Queenstown. And the purpose of this session is to try and take away from just all the sort of set presentations and answer a few of the questions that you guys have for a few experts that we've lined up here with a real breadth of experience. My role is pretty much just going to be moderating. My background is that I'm a nurse in ED. We've got a panel of doctors. I'll try and keep them in check, as my job usually is. And perhaps if we need a nursing perspective, I'll throw it in there. But you will have seen the QR code up. It is going to flick sort of between the screens, but make sure you scan it, send in your questions. They're going to come straight to me. You can make them anonymous. If you want to sort of target one person on the panel, then feel free. And we'll try and sort of flick through some questions and get through as many as we can. But look, we'll jump straight in. And so to start, we might just run through sort of a bit about who you are, where you work. And I reckon maybe your top restaurant recommendation, Queenstown.
Right, my name's Erin. I currently work at Logan, which is in southeast Queensland. I'm a late stage emergency medicine reg, about to become a consultant, about 3 months to go. Previous lives in pharmacy and public health. So this is definitely my last degree, last exam I'm ever going to do. And it's my first time in Queenstown, and I literally can't recommend anything except the Ferg burger, cheese and bacon pie for breakfast, which was excellent.
I'm Dan. I'm a FACEM and Medical Education Fellow at Rabina Hospital on the Gold Coast. My background's mostly in medical education and trauma, with a bit of retrieval medicine, but most of my training's all been done in major trauma centres, so a bit of experience in there. My recommendation is also Ferg pies. I think last year I was here, I tried every pie on their menu in the 5 days I was here. So
Breakfast, lunch and dinner, yeah.
Good morning, everyone. I spoke yesterday. I'm Mark Corden. I'm a paediatrician in PEM. I work at the Northern Hospital, which is similar to Logan, probably what was 10 years ago. So busy out of metro, multicultural populations, rural populations. And because I'm here with my 3 kids, the only food I've eaten has been nuggets and chips for 3 days. So I haven't got any good recommendations yet.
Fantastic. Nuggets and chips is a great recommendation. All right. So we're going to kick things off. We've had a few people. So this QR code was up yesterday. We've had a few people submit some questions. Mark, we might start with you, if that's okay. So this question, I think, right up your alley. Sort of, you love your difficult conversations, particularly in the paediatric space. So sort of when you've got a bit of prognostic uncertainty, do you have any sort of go-to phrases, or particularly when you're getting asked questions that you don't know the answer to yet, that kind of concern parents? I don't know, just that sort of, not giving them too much hope, but also not sort of just kind of really dire outlook.
Okay, so the context is probably like sick a child, or we're not quite sure what's going on. Look, this is a common conversation, and it doesn't have to be hard. I mean, outside the context, it's already a hard conversation. There's no tricks to it. We all are here because we want good outcomes for our patients. Parents and families and patients, they don't expect you to know everything. Deep down, they know they're little people too. So if they ask me some questions that I know the answers to, or I don't know the answers to more specifically, I'll say, look, yeah, that's a great question. That's the right question to ask. Because, you know, they're expressing their fears. So the first thing to do, I'm not quite sure, or talk over them, or say something, just to say something out. The first thing to say is just to go, validate the question, and where, I think what Will was saying yesterday, where the question is coming from, which is that sense of overwhelm, that anxiety. Because they, unless they live and work in hospitals, where they are right now is grossly foreign. In the middle of a resus day, it's awful. They have no grounding to their regular life, so they've got no capacity to really feel secure about anything. So the first thing is to acknowledge the question, go, yep, that's the right question. We know this and this. I don't know the answer to your question because I don't know what this and this is. So whilst I'm doing A, B, and C, I'm actually also going to see if I can find out the answer to your question. If that's going to be in a guideline, or if I can find any up-to-date articles, I will try and do that. So it's not being cocky, it's like acknowledging if I don't know something, I don't know it. And so it's just being absolutely genuine. The same genuine intent to find an answer to the question. If there's an answer, I'll try and find it. If there's not, I'll tell you that. It's just that honestly it's about just being as sincere as you can. We all come to work to do the best job we can, and it's communicating that at the same time as communicating, I'm going to try, and I'm going to try and find the best.
Yeah, fantastic. So the key is honesty in all of it.
Absolutely, the key is honesty and genuine intent.
Fantastic. Thank you. All right, we're getting our questions thick and fast here. Dan, I might switch to you if that's all right. So you said you work in a few hospitals now. You know, some better than others. So how do you manage? Like we've got a question here. That resistance to change. Sort of, you know, this is how we've always done it, and you know that attitude. How do you sort of come up against that and help to move things forward in medicine?
I think this is really common, especially coming into a new hospital. It's very easy to identify things that you've done differently, things that you think might work better when you come into a new space. I think the challenge is, and having sort of seen it from both sides now, is from your perspective, you're coming in and saying, I'm bringing fresh blood into this place and I've got all these great ideas. But from the other side, you've got this new person who showed up who doesn't know anyone and who doesn't know how things have happened and doesn't know how you've ended up in a position you're in saying, I know how to do things better and I'm going to change it all for the better. I think you need to work with the new hospital that you're coming into and with the sort of senior people that you're coming into the new place in, and to figure out the problems that I've identified, are they actually problems for everyone else, and the solutions that I've suggested, is it possible that they would work here, and then how can we trial that? But I think one of the biggest things is to find allies, and I think most emergency departments work sort of semi-like a democracy, where if you've got enough people that all support the same idea, you can push that change. And so if you come in as a registrar or come in as a new face and you link up with people at a similar level who have the same ideas, you can then sort of present this united front rather than coming in and being like, as an individual, I'm going to fix this place. Because I think that's just a surefire way to get everyone on the back foot. Whereas if you can come in and recruit allies and get everyone on board, I think you're then working with the department and pushing change rather than trying to change everything yourself.
Yeah, fantastic. Anyone else have a comment on that? We might, again, so many questions coming through, we might crack on to the next one. So this one, Erin, I might get one from everyone. But this one, so very simple, is how do you deal with burnout? Which, I mean, you just come through your exams, you've got 2 kids, we're living with them at the moment, they're wild, and you know, that's pretty full on. So how did you find that sort of process, and how did you manage, I guess, not burning you out? Or did you a bit and then, you know, have a strategy out of it?
Yeah, I think it's something that we all need to really keep on the top of our minds. Emergency medicine is getting harder and harder to work in. Access log, politics, staffing. We're waiting for the Coomera Hospital to be built, so maybe by the time I retire, that might be a thing. personally for myself, I've had a couple of experiences of burnout. I had my first baby at the start of med school, and then second at the start of internship, so that's been kind of part of my journey. I think the first thing you need to really know is when to identify in yourself the symptoms of burnout, whether you're snapping at people, whether you just don't want to go to work, whether whether there's like other changes, you're not finding happiness in what you do anymore. For myself personally, I know when I just want to lie on the ground and do nothing and stare at the ceiling, I know I'm burnt out, and so recognition is really key. I think it's very ingrained in our culture, in paramedicine, emergency medicine, to just push through, because that's what we do every day. But that does not lead to longevity and a long career and a fulfilling life. So recognition is the first thing, and then once I recognize and actually identify that and start telling people around me, so my husband, my friends, and just kind of actually verbalizing, yes, I'm burnt out, I need to change things, and that will have a domino effect. And and it's all the things that we know, just cut down if you can, cut down hours, take some time for yourself. It's always important to be in touch with your GP, and if you need to get some help. Even just 4 or 5 counselling sessions. I know, probably about 4 or 5 years ago, I was just really burnt to crisp, and I just needed someone to tell me that it was okay to be tired, it was okay to be a mum of young kids, and trying to study and trying to achieve things and feel tired, and that was just validating enough that just turned me around. I will say the past 6 months post the fellowship have been the roughest period of all, just in terms of trying to come down from that study work, trying to then keep going, because once you finish your fellowship, you suddenly look around and you're like, right, I need to do research, I need to do some quality improvement activities. You can't just walk into a job anymore. You need to have all of these other kind of CV buffing and good activities that you've done, things that you can say in an interview. So that is something I think that's really important for people to realise, is that even once you've achieved that goal of medicine, it's going to ask you for another one, and you have to be prepared to kind of recognise when it's too much and say no, it's enough.
Yeah, fantastic. Have you got any comments on that, Mark, with regard to sort of seeing your staff sort of burning out? Do you have anything that you perhaps recommend? Particularly we've got some juniors, we've got some interns, heading full force into then probably looking at training programs.
Burnout's it's such a highly personal thing each time. People burn out in their own time, their own way, and it happens a few times, and it will probably happen again to me. I felt very low at times as well, felt very burned out. I think a big example in terms of when you mentioned teams is during lockdown in Victoria, where we had obviously the most prolonged lockdown in the world. That was a huge time for staff attrition, lost a lot of staff, a lot of burnout, and a lot of burnout we were seeing in staff. If you have they were trying to relabel the burnout as you know what you want to be able to do for your patients, and you can't achieve that through bed access block, through lack of resources, through everything. You know what gold standard care looks like, and you're not delivering that care, and that creates the moral injury. And moral injury contributes heavily to burnout. So we're losing a lot of staff. There's no clear good answer to any of these questions. I think that what would resemble a good answer is what Erin said, is having someone to talk to, someone who understands. So ideally, someone who can provide care for you, like a GP. Peer networks that are constructive, not just, oh shit, I had this today, and everyone's just sort of being down and down and down, because it begets itself. You'll see these sorts of burnouts go in waves across departments, across sort of levels of structure. So it's encouraging people, and not just saying, go find someone to talk to, it's encouraging them through leadership. So you can give a person, I've started seeing someone, I'm happy to talk to everyone and anyone here. You can lead sideways, you can lead down, and for the juniors, residents, registrars, allied health, everyone else, you can lead up. You can recommend to your bosses to to do various things that you find are helpful to you and to your peers. So it's advocacy for yourself, it's advocacy for your peers, it's definitely talking and not carrying it alone. And the last sort of thing personally, when I had my first real experience of burnout, funnily enough, was when I was doing my year in adult medicine. And it was in a large West Australian hospital, and I felt like a cog in a machine. You know, we had the flow coordinators going, what's he playing, what's he playing, what's he playing? It felt about flow, and as a junior doctor, you don't really understand why flow is important, because it gets better health outcomes across the whole hospital. But right now, you just feel people are harassing you to move your patient on. You know, so they feel like a number, they feel like a box on a conveyor belt, and you're the wheel under turning the machine. And I lost the sense of humanity in what I was doing. Patients were numbers, they were statistics, they were the people. And when I sort of really hit low and just had a couple of really lovely conversations with a couple of elderly people, just to remember that everyone's trying their best, everyone's just to try and re-inject the humanity into what you do. And then we realise we have got very privileged jobs. We able to care for people around us and in our community. It's a marvellous place to be. It's an easy thing to forget. But when you can bring it back and go, oh shit, this is a lovely thing to do, to be able to do, then yeah, there's the good and the bad, but when it's good, it's really good.
Yeah, no, fantastic. Awesome. Yeah, we've had a few here that's just looking, you know, how do I switch off and how do I deal with burnout? And I think that was some great points there. And if anyone's got additional questions for these guys, we'll definitely be able to answer them. But we'll crack on.
Can I do one? Look, I'm on the switch off thing.
Go on.
The switch off question is a common question, and it's a question that is in our pro forma when we're interviewing consultants and registrars. Like, what do you do at the end of a shift? And like everyone always says, oh, I like to go for a walk, or I like to go to the gym. These are the young doctors without kids. Yeah. I like to do these things. And my reflection after having asked that exact question dozens and dozens of times, and dozens of trainees, like my response is, because I was reflecting, like, I don't switch off. Like I don't, but that's not necessarily a bad thing. You know, I'll take some of the work home with me. It sits there for a few days. It sort of filters and comes out. So I don't switch off. I can't, because that's not how I do it. It's not who I am. If you can go home, have a walk and switch off and be done, brilliant, do you. So I think the switch off thing, it's a very personal question and a very personal response. There is a pressure to switch off and go home and do some yoga or something. But I can't, I won't. But that's just my style. I think encouraging people to have their style. What helps you, again, personal, is very helpful. Yeah, thanks.
Thanks, Mark. Fantastic. I can see there is a fair few AI questions, and I do intend on looping back around to them. Someone's just very plainly said, "Is AI going to take my job?" We're gonna address AI. I do want to ask one before that because it could just simply run out the rest of our time. Dan, I think we've got a fair few paramedics in the room. And you've done a bit of that pre-hospital retrieval stuff. You've also been the receiving doctor in that resus room. What do you value as a receiving clinician? And this will go out to everyone. You know, you've all received patients. What do you value from our pre-hospital fellows as, you know, key information, or that thing you want to hear from them? I know, do you prefer that they come in with lines and stuff, or would you just love a good history? What is it that you really like?
Yeah, it's a good question, and I've been on both sides of it. I've seen from both sides, like poor handovers, but also receiving hospitals that do a poor job of receiving that handover. I've certainly given some handovers that I'm not proud of. I think being succinct is probably the main thing, and I think all of the through line for the pre-hospital job was momentum. And there's a few key moments where momentum comes to an absolute stop, and often it is when you're packing up to leave a scene, and it is when you hand the patient over. And because we do a hands-off handover, everyone stands still, and then getting everyone moving again is the biggest issue. And I think the longer that handover goes on, the less inclined people are to jump in and start doing things at the end of that handover. So I think we use an ISBUS style handover, we use at-mist and ample as our two mnemonics, and I think as succinct as possible within those headings, and then I think that would be my minimum. And if you do that, and then everyone can start working on the patient, and then if you've got more to say, and if there's a bit more of a story, and if there's a bit of colour to what you need to talk about, I think you can take the team leader aside afterwards, or take one of the doctors aside and say, look, here's some extra information about the scene, here's some extra information about the social stuff. But I think momentum is the key, and I think if you can get through your really succinct at best ample handover, and then let the receiving team start working on the patient, add all the colour afterwards. That's what I really like, and that's sort of how I drive my handovers from the receiving side.
Yeah, fantastic. I think I've got a colleague who he presented with me last year, James, really talks about that title line. I think that's fantastic. Like when you bring in a patient, or someone's arrested or something's happened in the ED, and everyone's there. It's just that really clear. This is a traumatic arrest, or this is a shocked paediatric patient, and all of a sudden everyone's just on that same page, and immediately clicks into gear of, oh, okay, I'll get fluid bottles, or oh, I'll get that. And you don't even have to ask as the in charge. So yeah, that's something that's definitely I value.
I think estimation of severity is the other one that I really like to hear from a pre-hospital team of this is a severe multi-trauma. And then that, in my mind, just switches everybody into that mode of we need to resuscitate this patient, we need to do it really aggressively, or this is a minorly injured person who's been in a rollover. I think that just sets the tone for the resuscitation. So an estimation of severity and sort of overall heading, and then a succinct handover. That'll do me.
Yeah, fantastic. Awesome. Should we breach the AI barrier? I think so. Look, I mean, this is definitely a question I had as well, and I think everyone's got. As I said, the question that came through was, is AI going to take our jobs? The other one that I sort of have, I guess, is it helpful or is it hindering? I mean, I had a patient the other day, mum came up and said, oh, Claude referred me in. And I didn't have a drop down for that. So I got a referral from GP as the triage nurse, I got self-referred, I didn't have AI referred me. In hindsight, it was actually relatively accurate, but I've definitely seen the flip side of it. So yeah, what do we think? Helpful or hindrance? What?
I think until they teach ChatGPT to do a manual disinfection, our jobs are safe.
Oh, you love that.
My personal opinion, I am as anti-AI as they come. I absolutely hate the generative AI, the large language models. I think they're a blight on humanity, but that is for the generative AI LLMs. And I think there is a lot of good work being done with medical targeted AI that is designed for purpose within the medical community and is trained on papers and guidelines and is strictly evidence-based, and that is in complete opposition to what we see people come in with, which is I ask ChatGPT, I ask Corden, and they've reproduced what they've skimmed from the surface level of the internet, and it's told me what I need. I think from that point of view, what I've seen personally is it is supercharging health anxiety, and that's the biggest issue from my point of view, is it is presenting worst case scenario to people with limited information as gospel, and that's what people come in with, and now you're no longer arguing against people's personal beliefs, but you're now arguing against the language models which they see as infallible, and you then need to deconstruct AI as a concept to be able to argue against these points that they're coming in with.
Yeah, I think before you jump in there, and that's answering one of the questions as well that we've had come through here, that was like, how do you reverse these parents that come in that have this diagnosis, or patients, just adult patients as well, they do it all the time. They just come in with this, like, I've got this diagnosis, and ChatGPT's reinforce that. Yes, you do have cancer, you've got a single one-off epistaxis. And so, yeah, how do you reverse that as well? I'll let you answer and just know what to think about.
Yeah, well, to be fair, I think that AI is a tool. It's never going to replace us, because medicine and humanity is the basis of medicine, right? I honestly think that like a cup of tea, a hug, and just giving someone a little bit of your time and love, like that's never going to be replaced by AI. I use Heidi, and that just has made me quite a lot more efficient, because now I can remember like the 15 medications that the patients are on, which right or left ankle that they broke. So I think, we're not going to lose our jobs, but they are going to significantly change in the next 10 years about what we do. And hopefully there's no radiologists in the room, because I don't think they're going to be employed.
maybe certain areas of medicine are a bit more vulnerable to others.
Yeah, I suspect so. But I really honestly think that, at the end of the day, people come to us for like that human interaction. I really think that most of what I do in terms of good for patients is listening to them, and then just being a human back to them. Like, you can know all of the guidelines, you can know all of this, but if you can't sit there with a parent who's lost a child, if you can't sit there and give a terminal diagnosis with some love and some humanity, then like, what are you here for, kind of thing.
Yeah, fantastic. You got something to say, Mark?
Always got something.
Always.
I think with the AI thing, it's extremely pervasive. I think it's definitely one to be very, very careful of, as Dan said, but it's not going away. We know that roughly 1 in 6 adult Americans will consult an AI per month for health questions and scenarios. So they will be coming with AI things. And we know that doctors, we might think it's going to replace us, but a large language model will fill in the next best word based on what the past words were to make up the sentences, to make up its modelling. And if you're a doctor and you ask it for advice on a topic you don't know about, evidence says you don't know how to discriminate whether you're getting good or bad advice. But whatever advice you get, good or bad, it's bloody confidently given by the AI model. The language and the grammar is fantastic, the bullet points are compelling, so you will believe it. And the other evidence, just recently, I think this year, a PLOS study was, if you know your content very well, and the AI is giving you evidence that contradicts, but should get you to question it, you still don't. So we are as susceptible to being convinced by the AI as everyone else. From an information gathering thing with families, I might have a chat about it, and they, for years they've said, oh look, I know I'm not supposed to Google it. I'm like, Google away. You may as well have as many points of information as you can to generate all of your questions, and then we can talk about those questions. I actually really like it when families Google. They know that they're going to get not quite right, but they're going to get enough information that we can have a better informed choice. I'm like, you're here, you want to have a conversation, you've done some work, that's great. We're already 3 steps ahead, let's go. And now it's the same conversation, but if it's AI. AI said this, or Gemini said this. I'm like, brilliant. It might not be perfect, but you've got some really good things to talk about, let's do it. So I'm not as anti-AI. I think if you're trying to apply it really directly to the patient, or they're trying to apply it directly to you, it's a challenge. But if it's, again, an information gathering sort of system and device that generates good discussion, then technically I'm all for it.
Yeah, fantastic. Yeah, some good perspectives on a very evolving field, as you said. Now I forgot to keep time. How are we going, Quinton? We've got 5 minutes left? Right. There's another good question here. Before I reckon we might just finish on some sort of rapid fire questions. So someone here. So New Zealand EDs have been suffering from long waits. Patients in the wait room for 24 hours, admitted, no bed. And there's been deaths in the wait room, which, I mean, I come from Gold Coast, which is one of the busiest in Oz, if not the busiest. And much the same thing, definitely doesn't sound quite as bad as this. So the question was, how are your hospitals in Oz dealing with this? We've got 3 different hospitals represented, but, you know, I might start with you, Erin. You're in Logan, you know.
Yeah, Logan's very busy. Like, we can often come on with 30 waiting to be admitted, an entire new department waiting on the ramp and in the waiting room. There's been a few different approaches. Access block is a big problem in our hospital. So the ED has tried to kind of approach wait times, ramping, and long waits in the waiting room with a few different things. One is we've got ICPs, interim care plans. So if orthopedics, gen surge, any kind of image-proven pathologies are slammed up condition, we can put them onto the ward and they can be reviewed by the registrar there. So that's good. We've had a lot of pushback sometimes from the inpatient regs. The deputy director is now working on a plan where if we refer a patient but they're not seen in 8 hours by gynae, medicine, renal, which does happen, we hopefully will be able to then just punt them to the ward too. So try and get some flow out. Some things within the department that we've been doing. So outside of the hospital health service funding, the government has funded 7 ramp kind of monitored beds. So it's 7 beds, 2 nurses are funded by the state, so outside of the HHS, to run those beds. So it's just simply because we don't have space, and there's a protocol to offload them, like patients who are appropriate. So elderly patients who can't be sent to the waiting room, people with unstable vitals, intoxicated people. So that helps as well. The next initiative that's really helped was that they funded a phlebotomist. So there's a person whose only job is to put lines in and take nurse-initiated bloods. So that's all the waiting room, and they also go to the ramp. So that really, that's picking up those elevated troponins, those CRPs of 5,000 that we that can just help kind of alert things. Secondary to that, there's an ECG tech who does all the ECG, so all our chest pains, even if they're in the waiting room, they've got an ECG reviewed by a consultant within 10 to 15 minutes. So that has helped as well, just avoid those STEMIs in the waiting room for hours situation. And then the last thing, and then we've got a CROC, which has been modelled off the Gold Coast Commander model, with some early senior decision making, with like a consultant who's got access to the REM and just mainly has oversight for all of that.
Yeah, fantastic. I think we might leave that point there, but we'll just quickly comment. So I've worked in New Zealand and in Australia, and it does, like as you mentioned, you've been sort of blessed with a bit of resourcing, and this does unfortunately sometimes come from higher ups, people that aren't on the floor, to really push for more staff. And for us, it's workloads. I can't remember there's a tool that you use in New Zealand where you have to fill in, like, you know, each patient you see and how long you took with them, that sort of thing. And what was it called? Trend care, yeah. It was frustrating. It was horrible. It was like, oh, hey, do more work in order to then get more staff, which was hard when you were already so busy. But it is really hard, and we do have to keep crying out. And I think whenever we get the complaints from patients, I just say, hey, go to your local member. I agree, this is horrible. And so yeah, there's definitely some differences between Australia and New Zealand where, but I think that's some fantastic things to consider and model. Yeah, go there.
The only other thing I'd add is that there is very, very good evidence that over-census patients are safer on the wards than they are in ED. So if the patient has been admitted and is just waiting a ward bed, they are safer being in an overflow bed on a ward in a corridor than they are being in a corridor in the ED. And so I would say for the senior staff, and if you get in the ear of your senior staff, you should be pushing exec to say these wards need to take these over-census patients because patient outcomes are better.
Yeah, perfect. All right, just to end things, maybe just one from each of you. What would be sort of one line pearl of wisdom that you could offer to our attendees? It's a hard one on the spot. Can be anything. You obviously had a few questions about burnout, a few questions about AI and stuff. You know, whatever you feel. Who do we want to start with? Oh, go on, Dan. You got the mic.
Look, my biggest thing is have some intellectual pursuits outside of medicine. I think what you learn outside of medicine, the experiences that you have, the things you read, you bring that into the practice, you bring that into your life. And so I would say read books with philosophical messages, go and travel the world and bring those experiences back, and it will make you a better physician.
More EMS conferences.
Always.
You're the blessing value.
In that same thing, it's a job. It's a great job. But in the last few years, I've realised it's just a job and do other things. It'll make you a better doctor, nurse, paramedic.
Fantastic. Mark, you have the most time to think.
I think my lowest point in medicine was when I felt like a machine cog. And so when I was able to sit down with a couple, and it didn't take much time, it didn't make me less efficient as a junior doctor, and certainly not less efficient as a senior doctor, just to sort of sit on a chair or get on a knee and connect just once or twice a week. It doesn't have to be every patient every shift, but sort of connect with someone to re-inject the humanity into what you do and re-inject a bit into who you are, and that it sort of makes everything a bit more shiny, and it makes your job more pleasurable, and it makes your practice kinder and more effective. So just remember the people in front of you, and remember yourself, and it helps regenerate the humanity of what we do.
Fantastic. Right, should we give our panel a huge round of applause? I'm sure they'll be around a little bit longer, or if you truly want the unfiltered version, come and chat to them at the closing party.
Awesome. Thanks so much, Ollie, and also Erin, Dan, and Mark. Really appreciate that. We do have a missing five. Is it still missing one? Oh, let's see. Okay, so next to you under the seat. One left, one down. We found the missing five, so that's all good. Tomorrow we're back in our afternoon session, so get excited. We've got all of Victoria talking about crashes, and we've also got Dan talking about pediatric and cardiac arrest. So two great presentations there. But now it's free time. Go out, enjoy the sights and sounds of Queenstown. Have a great day. Enjoy the morning tomorrow, and I'll see you back in the afternoon. Thanks, guys.
Hang on, doing the workshops.